Introductory Mental Health Nursing, Chapter 11, Psychotic Disorders. This discussion will come from the textbook by Cynthia Kinchelow. We're going to get into Chapter 11, Psychotic Disorders. So let's talk about these psychotic disorders. First, we must discuss psychosis. Psychosis refers to a set of symptoms that includes perceptual disturbances, disorganized thinking, and behavior alterations. Psychosis is not an illness. These symptoms demonstrate the disorganization that is present in the individual's mental processes and reflect the behavior, emotional response, and thought processes of the individual who has lost contact with reality. People usually associate the disturbances of hearing voices or other atypical behaviors with psychosis. Those who experience these symptoms also tend to withdraw from society. So there are a number of different situations in which the symptoms of psychosis are manifested. They may be seen in some medical conditions such as delirium, medication toxicity, dementia, mood disorders, and other delusional disorders. Psychotic disorders affect the mind and the individual's ability to think clearly and respond effectively to the world around them. The major symptoms of psychotic disorders are delusions and hallucinations. So I'm going to bring a picture into your vision here into this site because it's an important point to talk about when we think about hallucinations, delusions, and illusions. So let's take a look at this pictorial. If you're a visual learner, hopefully this will help you. Hallucinations are false sensory perceptions that have no relation to reality and are not supported by actual environmental stimuli. When a hallucination occurs, the individual has the perception of seeing, which is visual, hearing, which is auditory, smelling, which is olfactory, feeling, which is tactile, or tasting, which is gustatory. They are feeling these things with their five senses, but there is actually no stimulus present. Olfactory and gustatory misperceptions account for a small percentage of the perceptual disturbances. Now, although all of these may occur, auditory hallucinations are the most common. So again, to review, hallucinations are sensory impressions without external stimuli. There's actually internal stimuli. So that means those sensations are coming from within the person. If your patient is having hallucinations, especially auditory or visual hallucinations, you need to find out as a nurse, what are those voices telling you? What is that internal stimuli telling you? The concern is that those voices may be telling them to do something to harm themselves or to harm others. And if those voices are telling them to do something, they are called command hallucinations. Now, those voices could be telling them to pick flowers and have a nice day, eat some ice cream, or those voices could be advising them to perform violent acts. So we really have to understand what the voices are telling them, and safety is going to be key. All right, let's talk about illusions. Illusions, when a patient has an illusion, these are experienced when sensory stimuli actually exist. So something is really there, but it's misinterpreted. In this picture, we have someone waving, but that wave is actually seen or perceived by the individual as maybe they're holding up a knife, okay? So the individual, another example is the individual may refer to spots on the floor as insects or an electric cord as a snake. So all important to understand. So let's talk about delusions now. Delusions are fixed false beliefs, and the behavior of others in the environment is directed at them personally. Okay, so we talk about these delusions or delusions of reference. Now, there's some common delusional themes, and they could be depressive. They could also be maybe erotic, believing that a famous actor or actress is in love with them. There could be delusional themes of grandiosity, believing that they're stronger than they are. Maybe they're a superhero. There are delusional themes of jealousy, being very possessive, maybe of a particular nurse and wanting the nurse to spend time with only with them. There could be, let's see, delusions of nihilistic. So nihilistic means that they believe that their arm is no longer there, or part of their body part or body is no longer there. There's also delusions surrounded through religiosity. Sometimes patients may believe that they are Jesus Christ. Maybe patients may believe that they are Cleopatra, right? But these delusions are firm, fixed, false beliefs, and you cannot change your patient's mind. You cannot reason with them. So you don't want to argue with this patient because you're not going to win, because this is a delusion and it's a firm, fixed, false belief. Okay, that's important to understand. Okay, so let's continue to discuss this patient with the psychotic disorder. Again, we have hallucinations with five senses. And again, this is internal stimuli, something that is actually not there. It's not external. So how would you deal with this patient, especially in an NCLEX kind of scenario? You would want to ask the person or say to the patient, I understand you're seeing something. Can you describe it? So if the patient describes something that is totally not there that you don't see, you don't want to say, that's not true, I don't see it. You would say something that acknowledges what the patient is seeing, and you want to encourage them to tell you more. So you could say something like, I understand that you are seeing something. Can you tell me a little bit about it? What you are seeing must be scary. Would you like to share? So those are some of the statements you can use when you are working with patients that have these perceptual disturbances or these hallucinations. So your patient that is in psychosis may also exhibit disorganized thinking. So when we talk about disorganized thinking, again, it is your delusions, a false fixed belief. Uh, they could be depressive, somatic, grandiose, or have persecution, delusions of reference, thought broadcasting, insertion, or withdrawal. So let's talk about these a little bit. So if your patient has depressive delusional themes, they may believe that they have committed a terrible deed, maybe as a terrorist attack. If they have somatic delusions, so the somatic delusions, they may believe that their body is disintegrating into another substance or may be infected with insects. If they have grandiose delusions, they may believe that they are stronger than a superhero in a movie. If they have delusions of persecution, they may believe that a mob is out to get them. Delusions of reference, they may believe that they are false fixed beliefs that the behavior of others in the environment is directed at them personally. Now, there's some delusions surrounded by thought, and the first one that we'll talk about is thought broadcasting. Thought broadcasting is in which the individual's thoughts can be heard by others. So they think that people can hear their thoughts. Thought insertion may also be claimed in which the individual believes the thoughts of others can be inserted into their mind. They may also have thought withdrawal, which indicates a belief that others are robbing thoughts from one's brain. So an example of thought withdrawal is an example if the patient were to say something, I wear this hat so they can't steal my ideas. Okay, so the most common delusional themes are related to thoughts of persecution, religious ideas, or somatic reference. So we also have continued disorganized thinking. So that's loose association or derailment. Okay, so when we think about loose association or derailment, loose association is sometimes called derailment, where the thoughts or ideas frequently jump from one topic to another that's not related. Okay, we think about word salad, and that's when the individual expresses random, unconnected, disorganized thoughts, which indicate severe impairment. So there is also neologisms, and that's when the individual makes up a word that has a specific meaning that doesn't have the same meaning to others. There is a very old episode in SVU where there was a schizophrenic patient and he had a son that was named Tate, and it was the anniversary of, I think, Tate's death. And the schizophrenic patient said, the Kashistis are coming to get me. And so Detective Benson and Stabler, they were trying to figure out what was going on. And then they realized that that was a neologism. The Kashistis was a word that was made up that only meant something to the suspect that they were working with at the time. So there also may be clang associations. And so they may be demonstrated with magnificent rhyming words, such as the sky is blue, so are you. 2 plus 2, much to do. So we fear, far and near. Okay, let's have a beer. Okay, so those are clang associations. It kind of reminds me of Dr. Seuss books. Lastly, on this slide, we have echolalia. And so this is which the individual repeats another's speech word for word. So the patient will repeat what is said word for word. Okay, so let's talk about the behavior alterations you can see if your patient has a psychotic disorder. So psychotic disorder is unpredictable. They can go from being agitated to aggressive, silly, childlike. They may be inappropriate, and that includes maybe sexual inappropriateness. They can have frenzied motor activity, or they could be frozen. They may have an unkempt appearance. One time I was at clinical, there was a patient that was schizophrenic. She was in a catatonic state, and she did not shower. She would not let them bathe her for about 3 months. Very unkempt, inappropriate dress. They may have poor impulse control. Again, sexually inappropriate. They may have outbursts. If you have an NCLEX question and you have a mental health scenario, maybe a patient that is schizophrenic or bipolar that's in a manic phase, and they're engaging in sexually inappropriate behavior or acts, the big thing that you want to do as the nurse is provide for the respect of their dignity. So you don't want to make a big deal, you don't want to shame them, but you want to make sure that they're safe. So you will carefully, discreetly, safely escort them out of the room, right, from this, compromising situation, and try to maintain their dignity. That's a big NCLEX concept. So when we think about catatonic behaviors, this is a decreased reaction to the surroundings. So the individual may be physically there in the room with you, but they are actually not there with you in spirit. So physically they're there, but not with their mind and their spirit. So that's something that you may see. So when you have a patient that is catatonic, They have decreased reaction to environmental surroundings. The movements may be severely decreased or absent and accompanied by a stupor or a lack of awareness of an orientation. Posturing is seen when the individual is in a trance-like state with a rigid, atypical posture, often held against gravity. They may resist efforts to be moved for extended periods of time in a crucifix position, for example. An extreme form of posturing is known as catalepsy. Waxy flexibility occurs when the individual remains fixed in one position until someone changes it. An arm, a leg, or another body part can be moved by another person until the body part will remain in that position until moved again. The individual with psychosis may demonstrate stereotyped, repetitive, purposeless movements such as rocking. They may also exhibit mannerisms, which are repetitive and goal-directed movements such as saluting or bowing. These behaviors involve excessive motor activity that is triggered by an internal, not an external stimuli. Another alteration in behavior seen in psychosis is echopraxia, where another person's movements are imitated. And echolalia is going to be the repeating of words, okay, repeating of words. So there's a lot of signs that go along with your schizophrenic patient. So we do have symptoms that can be considered positive and negative. In your textbook on page 176, box 11.4, it discusses the symptoms of schizophrenia. And while I discuss this, I'm going to bring over a visual aid that kind of helps you understand how this individual with schizophrenia may feel. So when we talk about the positive symptoms of schizophrenia, they're evidenced early in the progress of the disorder, and they're usually demonstrated in the initial contact that the individual has with the healthcare system. So those are positive symptoms, and I'm going to give you some examples in just a moment, but let's talk about negative symptoms. So these negative symptoms develop slowly over time, and they are reflected as the individual is not able to deal with the way the illness affects their life. So looking at table 11.4, there are some positive symptoms that you may see. The patient may have delusions, word salad, words that are jumbled together that doesn't have a specific meaning. You can't understand what they're saying. The clang associations, which is the rhyming, thought broadcasting, insertion. Thought broadcasting is thinking that everyone can read my mind. Thought insertion is that you're putting thoughts into my mind. Loose associations, associating things going from one topic to the other that it's not related. Illusions is a misrepresentation or misunderstanding of stimuli that is actually there, external stimuli. And then we have depersonalization. They feel like they're not really real. There's also unusual or bizarre behavior. It could be in their mannerisms or their way of dress or speaking. There could be agitation as well as catatonia. And remember, if a patient is in a catatonic state, they may sit in a trance, in a stupor. They may not respond. They may not talk. They may just be staring straight ahead. And they can do this for minutes, maybe even hours or days at a time. So those were all positive symptoms. Let's talk about negative symptoms. So they may have a blunt or a flat affect. They will not show any emotions on their face, no facial expression of emotions. They may have a lack of energy, anergia. A is without, energia is energy. They also may have what's called anhedonia, and that is failure to find pleasure in activities that they once enjoyed. So that is anhedonia. They may have avolition, and avolition is a lack of motivation. So they also may not be able to carry out the activities of daily living. They may not be able to carry out simple hygiene tasks. They may not be able to interact with others. They may have what's called impoverished speech, is allogia, so not having the words to express themselves. That's impoverished or poor speech. They may also be using substances. Now, dual diagnosis is a term you should be familiar with. Dual diagnosis means that the patient has two primary diagnoses. One is a mental illness, like schizophrenia, and then the second diagnosis is going to be substance abuse. And we talked about substance abuse in previous chapters. And substance abuse can be alcohol, drugs, prescribed medication, could be one of many things or a combination. But substance use is something that is a negative symptom in schizophrenia. We also may see depression or suicidal acts and violent behavior. Okay, so again, this is your schizophrenic patient, and this picture is really accurate because it's pretty lonely. They're really isolated as a schizophrenic. So we talked about these kinds of words here. We talked about the negative symptoms, and whenever you have a patient that is in psychosis, one of the primary nursing concerns is to provide safety for the patient because the patient's judgment is impaired. The patient's not going to be able to keep themselves safe. The big concern when we think about the incidence of schizophrenia and when does it actually occur, when is the onset, it usually starts in late adolescence. Now, there have been rare cases where you have pediatric patients that present as schizophrenic, but it usually starts in late adolescence, early 20s, all the way to mid 30s. It manifests differently in men and women. So males, the beginning, when a patient may start showing these signs is usually 18 to 25, and females 25 to 30. And it affects about 1% of the population. And there is a thought to be a genetic factor, as with all mental illness, there is a genetic component. And unfortunately, this individual will have a lifetime of symptoms. Now, a lot of times, if your schizophrenic stays on the appropriate medication that has found to be effective, they may be able to manage their schizophrenia. But this is a lifetime kind of condition. So, how do we treat a patient that has schizophrenia? Well, medications, psychotherapy, and this is a reoccurring theme that we see with patients that have mental illness. We will use the appropriate medication as well as therapy. And the therapy for schizophrenia is going to be individual therapy as well as group therapy, family therapy. If the patient is not taking their medications or the medications are not effective, they may have to be hospitalized during acute episodes so they can be stabilized. That's really important to understand. So the medications that this individual may take, the schizophrenic may take, is going to be antipsychotic medications. Now, antipsychotic medications can be referred to as neuroleptics, and they're used to treat serious mental illnesses such as bipolar disorder, major depressive disorder, substance-induced psychosis, as well as schizophrenia, and also autism spectrum disorder. Because the symptoms of psychosis are extremely uncomfortable for most individuals, the effects of antipsychotic medications are often a relief. They can reverse most or all of the symptoms in many individuals with a psychotic disorder. Early medications, such as chlorpromazine, induced remarkable reversal in the symptoms and resulted in a dramatic decrease in the number of patients that were confined to mental institution. and that's chloropromazine. So that was an early medication that really helped these patients that were in psychosis. Now, typical antipsychotics, also known as traditional antipsychotics, they block various dopamine receptors in the brain. Due to their varied chemical structures and strength, these agents are grouped into high, moderate, and low potency classes. And so what we're talking about is potency, is how much of the medication is required in order for it to be effective. So let's talk about one thing that's really important, our geriatric patient. And this is something that you should always think about when we think about a geriatric patient, is that whenever there is a condition, the medication of choice should be the lowest possible dose, because we're always concerned about medication toxicity in the older adult or the geriatric patient. So in the older adult, the half-life of a medication tends to increase as much as 5 to 6 times, increasing the risk of toxicity. The effects may accumulate slowly and may not be apparent for days or weeks uh, after the initiation of the medication. So in your older patients, you also want to consider whether a new symptom or behavior may be related to the medication therapy. So really important for your geriatric patient. Okay, so we talked about antipsychotic drug agents, and they really serve to block those dopamine receptors in the brain, and they're available in different potencies. And I just emphasize the importance of the lowest possible dose in our geriatric patient. Now, these atypical agents, they help to reduce the negative symptoms. Remember, schizophrenia has positive symptoms and negative symptoms, and these negative symptoms develop slowly over time. They are reflected in the individual's inability to deal with the way their illness affects their life. Now, unfortunately, this will be devastating, and it can result in isolation and withdrawal. And so this individual may not be able to interact with others. Let's talk about some of the side effects that these treatments can have. We talk about these medications, these antipsychotic medications, or these neuroleptics. We're going to look at these side effects, potential side effects that may be faced. So extrapyramidal side effects. So these are drug-induced movement disorders. So these antipsychotic medications can produce numerous side effects. Lower potency medications tend to produce anticholinergic effects like dry mouth, urine retention, constipation, and blurred vision. I'm going to say that again. When we think about lower potency, right, lower strength medications that are used, antipsychotic medications, we think about anticholinergic effects, and that anticholinergic dries everything up. So dry mouth, holding on to urine, urine retention, and constipation and blurred vision. They also produce the antiadrenergic actions, including hypotension. The higher potency antipsychotic medications can produce severe extrapyramidal side effects. So these are what we call these drug-induced movement disorders. So let's talk about these different movements. So this is going to be in your textbook on page 183, box 11.6. Extrapyramidal side effects or drug-induced movement disorders. Well, the first one is akathisia. And so this is motor restlessness, the inability to sit still. So that's akathisia. Motor restlessness, inability to sit still. Then we have dystonia. rigidity in the muscles that control posture, gait, or eye movement. We have tardive dyskinesia, which is a late stage. That's going to be really important when we talk about tardive dyskinesia. This is a late stage, irreversible movement disorder. There's movements of the mouth, the face, that includes lip smacking, tongue thrusting, grinding of the teeth, again, protruding of the tongue. This individual will have mask-like faces, meaning that they will not be able to express emotions on their face, similar to your Parkinson's patient. They will have tremors, shuffling gait, cogwheel rigidity, pill rolling, and stoop posture. And again, very similar to your Parkinson's patient. Okay, they may also have drug-induced Parkinsonism. And again, these are symptoms that mimic Parkinsonism, such as the tremors, the rigidity, the absence of movement, or the diminished mental state. Lastly is the neuroleptic malignant syndrome. That's a really huge NCLEX concept when it comes to mental health. So this is a potentially fatal reaction seen with high potency antipsychotic agents. Again, this is your neuroleptic malignant syndrome. So it is a potentially fatal reaction with high potency antipsychotic agents. This response typically has an onset 3 to 9 days after treatment and is initiated. So what does a patient with neuroleptic malignant syndrome look like? Well, they can have muscular rigidity, tremors, the inability to speak, altered level of consciousness, hyperthermia, autonomic dysfunction, to include hypertension, tachycardia, tachypnea, diaphoresis. So hypertension is high blood pressure. Tachycardia is going to be a heart rate over 100 beats per minute, and tachypnea is going to be many respirations, over 20 breaths per minute. And diaphoresis is sweating. They will also suffer from an elevated white blood cell count. So although neuroleptic malignant syndrome occurs in a very low percentage of clients or patients taking these medications, the need for early recognition and immediate medical intervention is imperative. This is a really important NCLEX concept that you could see, and you should recognize if your patient is taking antipsychotics or neuroleptics, right? Those are the class of medications. If they have this high fever, this high heart rate, this high blood pressure, high breathing, you need to recognize that this is possibly neuroleptic malignant syndrome. You need to stop the medication, hold the dose, contact the healthcare provider. That is a huge NCLEX concept that you must be aware of. Okay. All right, we talked about older adults, and that's, again, we're worried about toxicity, So let's now go into anti-Parkinsonian medications. So anti-Parkinsonian medications are used to relieve the medication-induced extrapyramidal symptoms associated with antipsychotic medication agents. So the two most commonly used are benztropine and then trihexyphenidyl. Okay, so benztropine and trihexyphenidyl. These medications are synthetic anticholinergic agents that resemble both atropine and diphenhydramine, which is your Benadryl, right? And they closely resemble them in their chemical structure. So the fact that they are anticholinergics, right? Anticholinergic agents tell me that there's going to be some dry mouth, right? Urine retention, right? Decreased secretions. So we have to watch out for this. So the main contraindications to anti-Parkinsonian medications is hypersensitivity to the medication, of course, narrow angle glaucoma. This is a big NCLEX concept as well. Narrow angle glaucoma. So these medications, these anti-Parkinsonian kinds of medications are contraindicated in, of course, patients that are allergic, hypersensitive, but narrow angle glaucoma, patients that have myasthenia gravis, urinary retention, which makes sense because it increases urinary retention. Also, who else is contraindicated? Those that have peptic ulcer disease, those that have prostatic hypertrophy, they have an enlarged prostate. So these medications, we're talking about anti-Parkinsonian kind of medications, they must be used with caution in older adults because of the significant side effects, okay, including your urinary retention, visual disturbances, palpitations, and increased ocular pressure. Well, that makes sense. We just talked about glaucoma. We talked about myasthenia gravis. We talked about urinary retention. We talked about peptic ulcer and enlarged prostate. So if the patient suffers from these conditions, we don't want to give them this anti-Parkinsonian medication. A very, very important NCLEX concept to understand. So let's talk about the nurse's role. So we always want to use ADPI. When we assess this patient, we're of course going to get the very best possible history. We're going to assess whether or not the patient is experiencing hallucinations, delusions, or if they have illusions. We're going to be looking for those 3 items. Okay, we're also going to be looking at the patient's presentation. Are they dressed appropriately? We're going to be looking at their speech, looking at how their speech and their behavior, is it congruent? Does it make sense? Is it normal speech? We're going to be looking at their hygiene. Are they able to carry out their activities of daily living? So these are all things that we're going to do in the beginning to assess our patient. And then we're going to look at our nursing diagnosis. We're going to think, okay, what's really important? What are the things we're going to focus on? And with your mentally ill patients, safety is always going to be one of your priorities. And safety as related to altered thought processes, that's important. Also, we want to look at, okay, another nursing focus is going to be chronic confusion related to non-reality based thinking. So these are some of the nursing diagnoses that you may see. And of course, the goal of the nurse is to keep the patient safe, to make sure the patient doesn't injure themselves or that they injure others. We want the patient to also to make reality-based statements. All of these things are going to be great things to do for your patient. We also want the patient to demonstrate increased trust of others because there is a type of schizophrenia, which is called paranoid schizophrenia, where the patient may think that people are out to get them. So people may be trying to poison them. So they may only eat foods that are wrapped in plastic. They won't eat anything unless it comes in the wrapper. So these are all things to kind of think about. Let me just make sure. So let me just mention a few more things with schizophrenia. So I mentioned the paranoid type of schizophrenic. Again, people are maybe trying to harm them. Okay, disorganized type of schizophrenia, they have disorganized and unintelligible speech. Okay, catatonic type of schizophrenia, they may be mute or they may suddenly start repeating words heard at an earlier time. They may have irregular motions with their arms. Again, this waxy flexibility. They may exhibit mannerisms. There's an undifferentiated type of schizophrenia where they have a number of classic symptoms such as delusions, hallucinations. They may have disorganized speech, atypical behavior, and blunted affect. So they're not showing any much emotions at all. Okay, and there may be the residual type of schizophrenia, which is a subtype of schizophrenia, and the patient may have prominent psychotic symptoms with a previous diagnosis of schizophrenia, but they no longer have these prominent symptoms. So this is residual, okay? So sometimes they might have unrealistic thinking, or they may have social withdrawal. So again, your patient, we want them to be safe. We want them to be able to make reality-based statements, understand reality when they are expressing or feeling or suffering from a psychotic disorder, I should say. So we want to teach the family, educate the family, and let the family understand that the patient may not necessarily be compliant with their medication, not because they're willfully disregarding it, but they may be not compliant because they don't understand. So that's something else to educate the patient and their family members about. Okay. Let me go back. Okay. So when we assess our patient that is suffering from this kind of psychotic disorder, again, we're going to assess using the nursing process, looking at their speech, their hygiene, their ADLs. Are they able to carry out their daily activities? Do they express any suicidal or homicidal intent? Again, what are the voices telling them to do? Safety is going to be important, and grounding them back to reality is going to be important. Let's take a look at question number 1. Tell whether the following statement is true or false. Individuals who believe that others are sending messages to them or that they can send messages are said to be having delusions of reference. Is that true or false? Take a moment to pause the video and think about your answer. This is true. A delusion of reference is a false belief that the behavior of others refers to oneself. Again, a delusion of reference. So if they see someone standing at the bus stop, they may say, okay, this person is waiting for me to come talk to them. Actually, no, the person is there standing waiting for the bus. Okay, question number 2. Which of the following refers to a jumble of unconnected and disorganized thoughts? Is it allogia, catatonic behaviors, poverty of speech, or word salad? Take a moment to pause the video. It is actually D, word salad. So word salad refers to fragmented speech patterns that demonstrate disorganized thought processes. Okay, so what they're saying doesn't make any sense. It's a jumble of random words that are put together. So this is really a great chapter. There's a lot of information. So take some time to review it. Remember that when a patient has psychosis, they have a set of symptoms that includes perceptual disturbances, disorganized thinking, and behavior alterations. So this, you want to think about hallucinations, illusions, delusions. You want to think about different types of schizophrenia, positive symptoms versus negative symptoms. You want to think about the different types again of schizophrenia. So paranoid, disorganized, catatonic, undifferentiated, and residual type. You want to think about the treatment, which is antipsychotic medication or neuroleptics, and then think about the potential side effects of this treatment, and that's going to be your extrapyramidal side effects, those extra movements. That's your akathisia, your dystonia, tardive dyskinesia, late stage irreversible, right? And then drug-induced Parkinsonism, and then your neuroleptic malignant syndrome. These are all important concepts to understand with psychosis disorder. And lastly, remember your concerns for the geriatric patient. We want the lowest possible dose because we are concerned about toxicity. This concludes our discussion of Chapter 11. Thank you for your attention, and I hope this video was helpful. And remember to think like a nurse. Thank you.